Okay, well, good morning. I have the pleasure of introducing Dr. Jason Nagata. He is a physician as well as has a master's in science and is assistant professor of pediatrics in the Division of Adolescent and Young Adult Medicine at UCSF. And he just recently got awarded a K for the work that he's doing, for which we're very proud and excited for him. He's also affiliate faculty for the Institute for Global Health Sciences at UCSF. Notably, he's a co-founder and co-chair of the International Association for Adolescent Health, Young Professionals Network. And today he's going to be talking to us about research priorities for adolescent health in low and middle income countries based on work that he's conducted with the World Health Organization. And specifically since 2008, he has conducted food insecurity and nutrition research in Kenya. And we'll discuss this recent research on adolescent health in collaboration with the Shamba Mashai study. So thank you very much for joining us, and I'll let you take it away. For those who are not asking questions, if you could please stay on mute and batch your questions. There'll be about 3 opportunities during Dr. Nagata's talk where you can ask questions. You can always put it in the chat as well. All right, thank you very much.
Thank you. Okay, I'm just going to share my slides. Okay, are you all able to me and see the slides okay? Okay, great. So yeah, today I'm going to be talking about global adolescent health. I'm super excited to see all of you. I think I've worked with most of you on your adolescent medicine rotation last year. And so I'm super excited to share with you one aspect of adolescent health, which is international considerations in adolescent health. And part of this talk will be talking about like general topics for adolescent health, but I think that also as a recent trainee and relatively like new faculty who's not so far ahead of you all in terms of his career, a secondary objective will just be to talk about career development and how I kind of navigated global health at UCSF and just during my training, particularly during residency, and then also just some lessons learned along the way. So hopefully, I've organized this into 3 different like case studies, sort of like 3 different types of projects that I've gotten involved with that have allowed me to be involved with adolescent health globally. So the first sort of topic is going to be talking about research priorities for adolescent health in low and middle income countries, which is based on some work that I was able to do with WHO. The second one is related to HIV and food insecurity research in Kenya, which I started as a medical student and have continued to today. And then the last sort of area will be working with like a professional organization, which is the International Association for Adolescent Health, Young Professionals Network. So for each of these cases, as I mentioned, I'll start with a didactic presentation about like the research findings, but then the second part will be kind of talking about behind the scenes, like how I got involved in the projects and lessons learned. So the first case study will be talking about setting research priorities in global adolescent health. So actually, just as a start, what are we use like terms adolescents and youth and young adults, and I feel like sometimes we use them interchangeably, but it's not always clear to most people what exactly those age ranges are. Does anybody want to like provide some guesses or what your thoughts are about like the different age ranges for adolescents versus youth versus young adults, just based on even what we do here at UCSF or general knowledge? You can put them in the chat. Yeah, okay, great. 12 to 19 for adolescents. And then what do you think is the threshold for young adulthood? So this is actually a sort of chart from the Lancet Child and Adolescent Health, which is actually their most cited article because nobody really knows what these definitions are. So it's kind of defining these age ranges of adolescents, teenagers, older adolescents, and stuff like that. And I think a lot of people do use them interchangeably. And so technically, the current definition of adolescence, like per WHO, is 10 to 19. But as you can see, and then like young adulthood is like a little bit more nebulous. Like in general, can start around like 18 or so and go up to 30. Some people, but there's a little bit of variety, like at UCSF, we only see up to age 26, but other groups or organizations go up to age 30. So I thought this was just a helpful schematic about like the different types of age ranges. And I guess technically youth is really more like at older adolescents, like 15 to 24 or so. But anyway, I thought that this was interesting because we use often like youth and adolescents and emerging adults or young adults kind of interchangeably. Okay, so there are 1.2 billion adolescents with the WHO definition globally, and this makes up 16% of the world's population. And a majority of these adolescents live in low and middle income countries. And unfortunately, 97% of deaths of these young people occur in low and middle income countries. So there certainly are disparities, although there's really a minority of research that's done in these regions. So in terms of just WHO numbers for the top causes of mortality in boys, and this is broken up by younger adolescents 10 to 14, and then older adolescents 15 to 19. So actually you can see, like, especially among the older adolescent boys, actually road injury is the most common cause of mortality, then followed by interpersonal violence and self-harm. And then if we move on to girls, adolescent girls, in the younger adolescents, the top cause of death is lower respiratory infections, but in the older adolescents, it's actually maternal conditions and then followed by self-harm. So you can see that there are differences in sort of the epidemiology of mortality based on gender and then also based on age ranges. So as you may have noticed, even just from what's reflected in a lot of research in pediatrics and a lot of focus, traditionally child health is focused on under 5 mortality. And this is like the first 1,000 days is this really important time period and window. And traditionally adolescent health has been somewhat under researched and underfunded, because adolescents have generally been thought to have been healthy. But there has been more of a recent global emphasis on the importance of adolescent health. This is reflected from the UN's like Sustainable Development Goals. The UN also has a global strategy on women's and children's health, and they recently added specifically within their global strategy, like the term adolescence, which does have implications for like funding and focus. Also, there was a Lancet Commission on Adolescent Health and Wellbeing that came out in 2016, and the WHO has launched this global accelerated action for the health of adolescents, which is trying to really implement action plans at the national government levels. So I was fortunate to work on a project actually looking at research priorities for adolescent health, particularly in low and middle income countries, because of this paucity of research in low and middle income countries in particular. So the sort of topics that we reviewed were communicable diseases, injuries and violence, mental health, non-communicable diseases, nutrition, physical activity, and substance use. These reflected, some of those top causes of mortality and morbidity that we previously saw. And so those are sort of 8 of the priority research areas. And we actually used there's a sort of a research priority methodology called the Chinery Method that basically identifies experts and then in those 8 areas. And you can see those 8 areas there. And just of note, sexual and reproductive health is obviously a very important part of adolescent health, but that was done in a separate priorities exercise because it was such a comprehensive topic. So we use this method called the Child Health and Nutrition Research Initiative, or Chinery Method. It's actually the most common priority setting method since 2000. WHO uses it a lot, especially for child health. And the 3 phases of it include first just identifying the world experts in terms of research or program development in these topics. The second phase is then having those experts identify or propose different questions that they think are of priority in that field. And then the experts actually peer review or peer vote on each other's questions. So they all propose questions and then they like kind of vote and rank the whole group of questions to sort of get to a rank ordered list. So I worked on this survey development, and we sent out this three-step process to different experts in the adolescent health field on those 8 topics, and it was just done via online SurveyMonkey. So this is sort of an example of one of the results for just one area, communicable diseases, and I won't go through all of them because there are a lot, but just to highlight a few of the different areas. So first, in terms of mental health, and so these are the sort of final results, and they're like kind of ranked, and we ranked the top 10, but then also here are just some themes. So, the top mental health question was about the most cost-effective, affordable, and feasible package of interventions for promotion of mental health in adolescents. And there are some themes about integrating mental health management with like primary care or with reproductive health services or adolescent-friendly health services. In terms of nutrition, actually, the top question was, what are the top causes of anemia among adolescent girls, and how does this vary by region? A lot of them were epidemiology, kind of descriptive questions. 2 of the questions were related to like both overnutrition and undernutrition, and 3 were related to risk factors. So this just gives you a flavor of some of the sort of priority questions. These are the physical activity ones. This is more about context and theoretical models was the top question, looking at the different like systems and contexts that can predict patterns of physical activity. And then there was also an area on policy. So what platforms and strategies are the most effective to reach and help the most vulnerable adolescents? 3 were about primary care, and 3 were related to technology and innovation. So I mentioned that my particular project was looking at those 8 areas, but not the sexual and reproductive health area. But after then, those 2 processes were kind of done separately with separate groups of experts. Then I actually had the opportunity to like synthesize all of the questions from all of those areas, including all the reproductive health areas and then the areas that we had talked about. So this was just like a word cloud of all the top ranked questions from all the different exercises. So you can see sort of some of the trends like effects, treatment, schools, interventions. There were a lot of vulnerable adolescent populations that were identified. People living with HIV or TB or mental illness that were, particular note for research in vulnerable populations. Also, I sort of mentioned the UN global strategy that included adolescents for the first time. And so their paradigm actually was this concept of survive, thrive, and transform. So not just, kind of surviving through survival and mortality is important, but it's not the only health indicator. So really thinking about how teenagers can also thrive and, transform basically into healthy adults. And so we also organized the questions by those types of themes. And so, yeah, that was sort of 2 of the projects that we were working on related to adolescent research priorities. So that was sort of the findings, and then going to talk about sort of career development and lessons learned. So those projects actually were my global health track residency project. I knew that I was going to go into adolescent health, and I was very interested in trying to understand it from a very high level. And as I mentioned, the field of adolescent health is generally a younger field, and there's pretty limited research done especially globally. So I sort of had this dream or goal. I was like, I want to work at WHO because that's where like all the, like the policy and like important stuff gets done. And so some lessons that I learned through that process were, as I was, starting my global health track, I really wanted to like do an internship at WHO in their adolescent group, because I knew it was like kind of a new group and there's, a lot of work to be done. But, it ended up being a little bit of a challenge. I basically found out who the people at WHO who were working, on adolescent health stuff. I emailed, and it's actually very hard to find out who they all are. So I had to like basically go like it's their emails are not like listed publicly. So I had to go like try to figure out from reports and stuff what their names were. And then I know that the WHO like email rule is like last name, first initial at who.int. So I just had to make up all these combinations and like randomly send these emails to people, and like nobody ever responded. And I was like very sad. But it turns out that, Dr. Irwin, who many of you probably have rotated with, who's our division chief at the time, was the editor of the Journal of Adolescent Health. And, some of the WHO people were like associate editors on the board. And so I actually had mentioned to him that I was trying to do this and like I was not having a lot of success. And he was like, oh, just, forward me the email. I'll try to see what I can do or whatever. So then he emailed these same people that I had been like emailing like 5 times with no response. And then immediately they all were like, oh yeah, sure, you can work with us. And then I all of a sudden had 5 offers to work at WHO on this project. So I think that was just like a funny lesson for me to like, use the networks that we have. We're very lucky at UCSF and other places, to have some of those connections and stuff like that. The other lesson that I kind of learned was, Kirsten Domingo here is my primary research mentor for fellowship. And one of her like lessons to me was like to really focus on big, important questions that will change a field or clinical management. And then, to not sort of to like dream big and not to just ask a question because you can find like a significant p-value, but to really think about what is it that, will change clinical management or like will change a field, and really pursue those important questions and not kind of settle for mediocrity. And she's like one of the vice deans and like the chair of FB Biostat. So she had mentioned something like early in her career she was really like there's like certain number of papers that you have to publish to like get promoted and junior faculty, and she said she was like very worried about trying to get to that number so that she could make it to the next step. And her mentor, who was Lee Goldman, who's I think now the dean at Columbia, told her the same thing, like, don't worry about just focus, like just trying to like do small things, just, focus on a big question. And so that also kind of inspired me to want to like really think big about like global adolescent health. So, I mean, it seemed like those types of questions at WHO, like, what are the research priorities in adolescent health, like was one of those like really big questions, especially for a new field. And so, she was right. I, was able to go there for a few months and, learn how to do that Chinery methodology and apply it. And then, after publishing those papers, I think that really like got me, because there are so few people who like do global adolescent health. I think that like it sort of put me on the radar as like a early career like trainee. And so, it did open up some doors. Like I was able to go back after, completing that. I have been able to go back to Geneva to like, report on, those findings for different like, consultations and stuff. And then actually like, the South Africa Ministry of Public Health was trying to do a similar like Chinery exercise. And, there are not very many people who know how to do the stats for that. And so like I got invited to go, do it for South Africa. And so actually by the end of residency, I like got a all expense paid trip to go to South Africa to work on that. And then like later on, WHO did one specifically for like adolescent and pediatric HIV. And just like then hired me to do the analysis for that. So yeah, it was like I think it was a nice way to sort of, once you've developed a certain skill set that's unique, then people, if you're lucky, will come to you. And so that was kind of a nice lesson that I was able to learn from that. Okay, so that's sort of the end of that first case series. And I wanted to just pause for a second if anyone has any questions about that.
Hi, Jason. This is, I guess, like more of a general question about global health research, but since you kind of brought up like the academic culture to, get a certain number of papers published and to just kind of like try to focus on questions that really need to be answered instead of like our personal motivation to just move our careers ahead in like the physician scientist world. I'm wondering if you feel that those things are ever like at odds ethically with each other, like and how you can balance kind of trying to like move ahead and find your niche while also, helping problems that are actually there and like, listening to neighboring countries.
Yeah, I think that's a really good question. And I think it's a challenge, especially in like global health work, because I think there's a balance of I found that there's sort of this sweet spot where like there are some questions that are like really important to do, but it's hard to get funding, or like there's like a lot of logistical challenges to like actually answer the question that you want to have. So it's like a question of like what's feasible, given whatever resources or time constraints or things that you or your grant or your university have. And then there's what's like needed in the world or the community for whatever project you are. And then there's always like a balance between like and then obviously things that would ideally it would be something that is important, that there is funding for, that will also serve to benefit your career. And there's sort of, I feel like, a Venn diagram of those kind of things. And sometimes there are projects that are really good and important, but it's hard to get funding for, or that are, so anyway, that like there, and so yeah, there's no right or wrong answer, but I think if you are able to find that sweet spot of something that fulfills all those criteria, then, or as many of those criteria as can, then that's the best. But most projects don't do that, and then it's kind of like a question of what kind of prioritizing what is most important to you. And so yeah, I don't have a great or right answer, and I'll talk, I think, a little bit in the future how I've tried to like reconcile some of those things, because even though this was like kind of a cool residency project, I don't primarily, like, I don't have funding right now to do global health work, so I mostly am doing like national, like US based adolescent health research, and then I sort of just do global health stuff on the side if I can. So I haven't been able to find like the funding for global health work, but so yeah, it's an ongoing kind of struggle. I think ideally, if you do have a project that fulfills all those things, then you should go with that. But a lot of projects don't. Okay, great. So I will continue to move on then. The sort of second case study that I was going to talk about is research on food insecurity and HIV, so hunger and HIV, household food insecurity in Kenya. So this actually started with my medical school project at UCSF. I was also in this global health, I think, pathway from the beginning of medical school. And so I worked in Mfangano Island in Suba district in Kenya. So those arrows are pointing to exactly where that is. Suba district, so if you see like kind of the red over there, Suba district is sort of the area that has the highest HIV prevalence in Kenya. It's over 15%. And so that certainly is a hot spot for transmission. Food insecurity is defined as limited or uncertain availability of nutritionally adequate and safe foods. And actually, before I had started medical school, I deferred a year and I did a master's in medical anthropology, and had actually spent several months in in this island in Suba district, and did sort of mixed method, like qualitative and quantitative interviews on food insecurity. We found that 80% of people, of adults living with HIV, met the criteria for food insecurity, or actually for severe food insecurity. And from some of the qualitative interviews, we heard people say stuff like, when you're taking drugs or these ARVs, you feel so hungry, it just burns. And we also found that 30% of adults with HIV would be considered undernourished. So their BMI was under 18.5. So my main medical school capstone project was looking actually at a nutrition intervention, the food by prescription nutrition supplementation program for adults living with HIV in Nyanza province, Kenya. So that was the province in which Suba district was in. And the goal of that was to evaluate a food by prescription, a macronutrient intervention for adults living with HIV. So the intervention was basically a corn, soy flour, porridge that was fortified with different macronutrients and micronutrients that was actually given to people with HIV who were getting antiretroviral. So it's actually interesting because I know a lot of you have worked with me on the eating disorder service, and I'll talk about that later, but this is literally also food by prescription, but in a very different context. Basically people with HIV do have a lot of wasting, and it's shown that, as I mentioned, people are less adherent to their medications and stuff like that if they're on an empty stomach. So this program basically, along with their medications, provide prescribed food for people who had lower nutritional status. And so we did a retrospective chart review of all these patients who were getting food by prescription. So again, it wasn't a randomized trial or anything like that. It was just a descriptive study looking at who was getting these food supplements and what were some of their outcomes. And so on average, we did find that people who got food by prescription gained about 1.8 kilos in weight, or 0.65 kilos per meter squared in BMI. And the greatest gains were in the most severely malnourished patients. So those who started with severe malnutrition. However, only 20% of people actually from the prescription attained a BMI greater than 20. And those, the highest rate of attainment was among those who already were at a higher BMI to start. So had BMIs of greater than 18.5. And so that was sort of one step of my medical school research. And food by prescription is kind of like the adage, if you give a man a fish and you feed him for a day, but if you teach him to fish, you feed him for life. So this is just giving people food on a daily basis, but not necessarily giving them skills to get out of that. But and so actually, when I then moved on to residency and fellowship, I sort of was not active in this area anymore. But in the meantime, my mentors had developed sort of a more a sustainable intervention. So it was this Shamba Maisha study was a multi-sectoral agricultural intervention for people with HIV. So it was meant to address food insecurity, but rather than just giving people food, it was sort of microfinance loan for so that they could sort of jumpstart their farms, and also there's a lot of drought and seasonal issues, and so it provided them with a water pump so that they could pump water from Lake Victoria, so they weren't so dependent on the rainfalls, and then also some seeds and fertilizers and pesticides, and then also just some education and financial management and sustainable agriculture practices. So it's meant to be more of a livelihood, multi sectoral sustainable intervention. And so, this was a much larger study. Well, they had a pilot study initially that showed some, promising preliminary results. And then they got NIH funding to do a large cluster randomized control trial with 704 adults, and then 350 kids. But the kids were young kids, 6 months to 3 years old, who lived in these households. And so that all sort of was happening while I was in residency and the start of fellowship, and I wasn't really involved with it at that point. But at the time that I started fellowship, one, I guess, aspect was they realized that they weren't studying the teenagers at all. And so they actually then got a subsequent grant to start looking at the outcomes of the teenagers who were living in these households. And so there was an NIH grant that looked at sexual and reproductive health outcomes of the teenagers. And then I got a internal UCSF grant to look at the nutritional status of the teenagers. So there's a resource allocation program, the RAP program at UCSF, which does have some funding for smaller projects. And so that's just some fund that it's good to know about from UCSF. And there's also actually a UC-wide Global Food Initiative fellowship program, so that also provided a little bit of funding. So the overall goal of adolescent Chanbai was to see how this multi-sectoral intervention might improve food insecurity, and then also potentially some of the sexual reproductive health or nutritional outcomes in adolescents. And so I guess, and also the teen study was couched in obviously this much larger study, on adults and younger kids. And so it also provided opportunities to just look at some of the data, even outside of the main intervention aim. So these are just some recent studies looking at some of the teenage stuff, and because they did collect mental health outcomes, and then even other than food insecurity, there's even water insecurity measures. And so the trial is now completed, and some of the preliminary results are being analyzed right now, and hopefully by next time I can share those with you. But taking a step back and looking at career things and lessons learned for this project, I was just gonna go way back and say that I actually first got inspired to want to even do medicine, because actually I was when I was an undergrad, I read this book, Mountains Beyond Mountains. I don't know if any of you have read it or heard about it, but it's basically this New York Times bestseller about Paul Farmer, who is a Harvard medical MD, PhD, infectious disease doctor and medical anthropologist. And it's a very inspiring kind of New York Times bestseller about his life, even from college through medical school and early career development. And then eventually, he founded Partners in Health, which is a NGO in Haiti and Rwanda and Peru. And he's sort of this very inspiring story of scaling up this program. And so that was very inspiring to me as this bright-eyed undergrad who was unsure about his career. And so that really solidified for me wanting to pursue medicine. And I just really wanted to be a Paul Farmer groupie or whatever, and just do everything. And the book basically walks you through his from undergrad through his medical training. So I really tried to emulate him as a role model. And so I think that there was they had this phrase in there what would Paul do? It's kind of what would Jesus do or whatever. And so he talked about how he loved his patients and patient care. That's the title Mountains Beyond Mountains is because he would literally hike through all these mountains to see these patients in remote areas. And so he developed this second home in Conge in Haiti, using also sort of a medical anthropology framework. And he would really advocate for these things. And he had very catchy book titles called Infections and Inequalities or Pathologies of Power. And his role model was Rudolf Virchow, who was one of the founders of sort of modern public health as we know it. And so, yeah, I was really inspired by him. And so I would just every time he would give a talk or whatever, I would just try to go there and meet up with him. And yeah, we actually invited him to give a talk at our university, and he had lunch with us, and he was very nice. And so I sort of tried to think about how I could emulate all of those sort of qualities. I was lucky, I was going to UCSF. I had spent some time in Kenya, or like before starting medical school, I had spent several months in this island in Kenya, and that's where I had done my master's in medical anthropology. And I actually decided to defer med school to do the med anthro master's because that's what like I was like, I want to do medical anthropology just like Paul Farmer. And then so my like dissertation was hunger and HIV. So I tried to like follow that alliteration thing that he has in all of his books. And he was like my role model. And so, yeah, it was kind of like funny. I was just trying to like emulate him in as many ways as I could. But one thing that once I started med school at UCSF, when Paul goes to medical school at Harvard, he's actually like it talks about how he's actually known as Paul Foreigner, because he's actually like not really ever going to medical school. He spends like all of his free time in Haiti. And so he like is just brilliant. So he like obviously passes all of his classes with flying colors, and he's like already seeing patients. But he sort of had this whimsical lifestyle where like, at every moment he was just flying back and forth to Haiti and, building this organization, like while on top of being a medical student. And while it is very inspiring, I think I soon learned that was not exactly me. Like I actually needed to study for my exams. Like I can't just like go and do this stuff. And so so I think that I had a real reality check when I was in medical school, being like, oh, I don't think that I can really like keep up all this other stuff. I just need to like focus on passing my classes and stuff like that. And I think another sort of personal consideration for me was that during med school, I came out, and in Kenya, you can be imprisoned for 14 years for like any kind of same-sex activity or whatever. And so that was also something that sort of was a personal consideration for me, as I was like, as I continued to work here, like just thinking about like safety issues and stuff like that. And it also, I have to say, prevented me from coming out publicly for a long time, just because I had so many colleagues in Kenya and I didn't want for them to like find out either like on Facebook or like social media or anything like that. And so I was actually more closeted, I think, than I would have been otherwise, because I had so many colleagues in Kenya who I wasn't sure would be like supportive, or I'm not sure how it would have ended up. Another, I don't know if anybody recognizes the other person in this picture with Paul Farmer, but this is Jim Kim. So he was sort of like the co-founder of Partners in Health, also like a Harvard MD PhD. And he is also, prominently featured in the book, and he went on to actually like be the president of Dartmouth, and then he was the president of the World Bank for a while. So he also had a pretty successful and illustrious career as well in global health. And so he was sort of in the book, he was like more like the more practical one. Like Paul was like very dreamy and like flying and doing something. The Jim was kind of more practical. And so I then sort of shifted my focus to be like, what would Jim Kim do? Because I was like, okay, I need to be a little more practical with my global health stuff. Like, he was like practical Asian immigrant parents. There's like this really funny quote in the book where he like, I don't know, comes back from college where, his immigrant parents like really want him to go to medical school. And he's like, oh, I learned all this stuff about social justice and stuff, and I'm going to be like a social justice major. And his Asian parents go, that's nice, Jim. You can do whatever you want after you finish residency. And I feel like that's something my parents would say. But he, similarly had a med anthro background, but he kind of, he took like I don't know if I would say a more practical approach, but he, like definitely, in the book, I think like Paul's like this sort of this dreamer or whatever. And I think Jim is like a little bit more like, okay, like how do we actually get this done? Like, how do we do things like, in a more scalable way. And so he like worked with WHO for a while. And then, as I mentioned, he like, had leadership positions. And so obviously was still very successful and impactful in global health, but sort of ended up having a slightly different approach than Paul. And so then I became a Jim Kim groupie and would go to all the Jim Kim events. And so this was when I was at UCSF as a medical student. They had a Dartmouth like fundraiser in San Francisco, and I did not go to Dartmouth, but I found one of my med school friends, and I was like, "Can you please go so that I can go and take me as a plus one so we can talk with Jim Kim?" So So yeah, that was sort of a shift in my thought process. But kind of like to address Kelly's question a little bit more. So, I had been involved with this larger Kenya program that actually a lot of it is coordinated at UCSF. So it's like this family AIDS care and education services. That was, the program for which I did the research that I was just talking about for food by prescription. And that, had some really great mentors, Sherry Weiser and Craig Cohen here, and they're both at UCSF in the Global Health Sciences division. And I think that model that I learned was, while there's lots of like people who are working on like these bigger projects, I guess one way to still be involved with global health is to sort of just take on a very small part of a larger project. So like, for instance, what worked out really nicely for that big trial was like they just needed somebody to help with like an adolescent focused part. And so I wasn't like responsible for the funding of the big project. The whole trial was already in place. We were just collecting data on like the teenagers who lived in those households. And so it was a little bit more feasible than trying to like, start a huge study from scratch. And so that was like sort of another model that I learned of like still being engaged in global health work, but joining on to like a larger program and a project that already has infrastructure and staffing. And so this was just our like training for the teen Shamba project. And again, like at this point, the study was already underway. There was already this whole research team staff there. We were just like basically adding measures and interviewing the teenagers who lived in the household. So it was much like less of a burden on everyone because there's already kind of stuff in place. So this is, just like the trainings for all the research assistants and interviewers for some of the adolescent focused questions. And I think the last thing that I've learned is this concept called like local health. So like local health is global health. And so with all this food insecurity work that I had done in Kenya, like there's obviously still food insecurity like in the US, and there's lots of disparities and inequalities, locally. And so I think that I've also shifted to like, even though it's a slightly different context, just start thinking about how some of these issues do shape out locally, and just realizing that, some of that local health like is global health, because like anything in the world is part of the global community. And so as I kind of have mentioned, I have shifted a little bit, and I have done more research recently on like domestic or like US based issues. But I do feel like they're still on these same themes of food insecurity and nutrition. And that actually is kind of how I shifted into eating disorder work. So yeah, from the beginning of like, I guess my education, like I've always been interested in nutrition. So as an undergrad, I did some research on malnutrition in Guatemala. As I mentioned, I studied food insecurity and undernutrition in Kenya, in grad school and med school. And then, since I have been in the Bay Area for med school, residency, and fellowship, I guess the local flavor of malnutrition is eating disorders. But interestingly enough, the physiology, like our whole refeeding protocol on the inpatient service is actually not dissimilar to the inpatient refeeding protocols like in sub-Saharan Africa for like severe acute malnutrition. Obviously the context is completely different. There's like a lot of, the mental health issues are different, but the physiology of starvation is actually the same. And so it was actually an interesting sort of parallel to be able to sort of transfer some of that knowledge and interest in malnutrition, to the local stage. And that's actually how I transitioned to eating disorder work. And so one other sort of, I think, advice that I got was to really try to align your clinical work with your research work, if possible, because I did feel also like, as I was going, like during residency, for instance, and even the beginning of fellowship, we didn't have a lot of like people living with HIV. And so I felt more and more like the research that I was doing was very different than like the clinical patients that I was seeing. And it felt like a little bit jarring to have to do a complete 180. And so, so I think that also was a reason why I sort of shifted into doing a little bit more eating disorders research lately, because it's like, okay, the research that I'm doing actually affects the patients that I'm currently seeing, and it's all kind of like aligned. And I have more recently focused on like male populations with eating disorders. But I think one other sort of lesson that I've learned is that, I think I had in my mind that there are certain types of diseases that you have to study to do global health, but actually eating disorders affect people globally too. And so one like kind of interesting way that I've now done more global health work is actually in the eating disorder worlds. And so we've had collaborations with people like in Argentina looking at different aspects of like muscle dysmorphia and eating disorders in Argentina, and then actually have like developed like one of the first measures for like muscularity oriented disordered eating. And that when you create a new measure, like all these people want to replicate it in different countries. And so actually in the last couple of years, we've worked on, with people translating it into all these different languages, which has been kind of cool and interesting. So I think it's been very, even though I don't think I would have ever imagined that I would do global health work and eating disorders, like that sort of is also how I've recently sort of transitioned. So yeah, some of the lessons that I sort of learned through this is, if you can, like joining a larger study group with an established infrastructure, and then taking on like a small and specific research question within that. Also recognizing that local health is included in global health, aligning your clinical work with the research if possible, and that you can, basically, there's no like one specialty that you have to do global health. Like you can do global health in any specialty. And so, and in some ways, if there are fewer people doing that, like in adolescent health or eating disorders, then it actually creates sort of a niche for you. So I think like early on in my career, I sort of thought that I was going to have to do ID or something like that in order to do global health, but I think that's not actually the case. So that was sort of this little case series on that. I don't know if anyone has any questions about.
There's a comment in the chat for you from Aaron. I'll let you read it instead of reading it out loud.
Okay, so for the, thank you, Meron. For the first one about the Adolescent Kenya project, were there any interventions focused on sustainable resources and education? So I think like the whole idea of that Chamba Maisha thing was that it was ideally going to be more sustainable, such that, if you show, or if you like are able to educate people on like more sustainable like so I guess I should have also given the background that a lot of these communities are sort of subsistence living, so a lot of their food insecurity is dependent on just what they are able to produce in their own farms, and I think one thing that's become increasingly more clear is like the effect of climate change and climate on health and nutrition. And so I think certainly what we had seen was that, when there were periods of really long droughts, that's when people were like the most food insecure. And so I think the idea behind the microfinance loan and the water pumps and stuff like that was to make it so that people weren't so dependent on just like the rain seasons, but that they could, even during the dry season or during periods of drought, they had like a way of irrigating their farms, so that they could still keep up with some of those produce. So I think that the idea of that intervention was that it would be more sustainable, and then also in educating people on how to sort of maintain that. I don't know if that answers your question.
Yeah, I think I was just wondering, sorry, there's some construction happening here, but if what you were doing for the adults kind of trickled down to the adolescents.
Oh, is that, yeah, sure. So yeah, I mean, these were household level interventions. So the adolescents, like, you know, I guess it was a household intervention, and so like the kids and the adolescents like would be theoretically affected by it, you know, because they live and get, I guess, eat with those households. But that was actually the main question of the study, was to see if like a household level intervention that wasn't necessarily aimed at adolescents would actually improve adolescent health, you know, sort of like a social determinants of health framework. So yeah, that's the main question. The analyses are, like, the study is just completed and we don't have the final results yet, but that's what that was the hypothesis. And then in terms of how your foundation in medical anthropology has framed your approach to research, I have to say that since I was always interested in nutrition, I did like sort of have a focus on nutritional anthropology. So certainly a lot of the work that I did with that, you know, informed just nutrition, like kind of methods and research. But I think in general, there are different like types of medical anthropology, and one is considered like a critical medical anthropology, which I think some people would say Paul Farmer is, where you're kind of thinking outside the box, always questioning like the biomedical complex, you know, like industrial complex, and like you know, why we do things the way that we do. And so I do think that has helped me to think about like research questions and trying to think outside of the box more, rather than just being just following things because that's what, like, how they've always been done. But I will say that my methods have moved a little bit more to more like quantitative and like epidemiology methods more recently, and I'm doing less of like the ethnography or qualitative stuff. But I do think that the sort of critical questioning has been very helpful in trying to think about like what are important questions and shaking things up a little bit. Thanks. Okay, so the last little bit, which will be short, is just like another sort of way that I've been able to get involved with the adolescent health kind of international and global community is through like a professional organization. So you know, just like there's like the AAP, which is like a US based organization, you know, it's obviously American. There's also like a US based adolescent society, so it's SAM, the Society for Adolescent Health and Medicine. But then the umbrella international organization for that, for like all the different national adolescent health organizations, is called the International Association for Adolescent Health. And so one, I think, thing of note is that there really is not a lot of adolescent focused health training programs. And there are actually, other than the US, like the SAM, the North American one, the SAM, there are actually few national professional societies in adolescent health. And so this International Association for Adolescent Health, you know, does provide some of those gaps, especially in regions and countries that don't have adolescent focused training programs or resources or organizations. And so there was a push to try to really engage like people like trainees and students and early career professionals to get more training skills in adolescent health. And so the president of this organization wanted to launch like a sort of a young professionals network focused aspect of the organization. And so invited me, since I had like done this WHO work and stuff like that, to be one of the sort of co-leads for that. And so over the last 3 years, I've been involved in trying to, you know, get early career professionals involved and provide sort of training resources for them. And so we have these, you know, 4 committees within our Young Professionals Network on communications, leadership and mentorship, community engagement, education and training. And we sort of developed a whole, you know, curriculum and stuff. So there's monthly webinars, there's education training resources database on the website. There's like a lot of social media presence, and we've worked with like a mentorship program that has started this summer and is going through the end of 2021. And so this is sort of our organizational structure of the different committees and leadership. And this is just a picture of the officers who are involved. And it's kind of cool that, yeah, there are representatives from like basically all the different WHO regions. So it's really fun to be involved with the organization like that. The only I think downside is that trying to schedule calls with everyone at the same time. I think people in North America and Australia get the worst time. So yesterday I had to wake up at 4 a.m. for this call, and it's like a monthly call. But other than that, it's been great. And I think that one other sort of quotation that inspired me from Mountains Beyond Mountains, that book, was they always quoted this Margaret Mead quote that's like, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. And I think that one thing that has been very helpful with sustaining like my interest in global health is just like, yeah, working with a small group of people who are really committed to like adolescent health, like in this Young Professionals Network, because it's just a lot more fun to do it with a team, and especially kind of a diverse team from all over the globe, even at 4 a.m. Yeah, see, there's just a summary of some of the lessons that I've learned. So like, perseverance, but first you don't succeed, try again, focusing on big important questions that will change a field, joining a larger study group or a project with an established infrastructure, and then taking on a small or specific part of that. Just knowing that local health is global health, so any local health work, still counts. Trying to align clinical work with research if possible, and doing it in any specialty is fine. Just a small group of teamwork can really make a big difference. So yeah, that's the end of the talk. I just have a lot of people to thank at UCSF, at IWH, at WHO, and then some funders. And so yeah, that is the end. I'm happy to take any other kind of final questions about anything.
Thank you so much, Jason. That was amazing and so fun. I didn't know most of that about your path, and it's funny because I also was inspired by Mountains Beyond Mountains, so I completely understand the inspiration, and love that you got a medical anthropology degree. That's so fun. Any questions in the chat, or people who want to come off mute and ask Jason some questions? And sorry, also as a reminder, we've put in the chat the brief session evaluation. If you could please click on that link. It's very short, I promise, but we do really value your feedback. And Jason, if people are interested in becoming involved, what's the best way to either reach out and ask if they have questions, or learn more about your experiences? Do you want them to email you directly?
Yeah, you can just email me. It's jason.nagata@ucsf.edu.
That's great. Thank you so much. Like I said, this is really fun, and I lived vicariously through your path as well. Great.
Yeah, thank you so much for attending and your interest in adolescent health.
All right. Thank you so much, everyone. Have a good rest of your day.